Our next speaker is Ethan Marin. He is an assistant professor of medicine and nephrology at the Yale School of Medicine and is an active researcher in the field of renal physiology. And he is going to speak to us on the TruGraf experience at Yale.
Hi, this is Ethan Marin. I'm in the section of nephrology and part of the renal transplant program at the Yale School of Medicine. And today I'm going to talk to you about our program for non-invasive monitoring of renal allograft function. Brief disclosure, as shown on the slide here. So at Yale, as with most transplant programs, we very intensively monitor our transplant recipients after the transplant event. We have frequent clinic visits in the first few months after transplant, including 2 a week for month 1, 1 a week for the second month, and 2 in the third month, followed by monthly visits thereafter. We do a lot of lab studies, creatinine, urinary albumin, et cetera, during this period of time to keep an eye on graft function. Typically at 6 months, our protocol is to do a biopsy at that point if everything is going well, and we do for-cause biopsies at any time during this first year. So why do we do a protocol biopsy at the 6-month point? The logic is that creatinine and proteinuria, while useful, are relatively insensitive and non-specific biomarkers for rejection and other pathologies. And there's literature to suggest, albeit with some controversy, that significant fractions of newly transplanted patients have subclinical rejection, meaning rejection even in the presence of normal creatinine and other parameters. Further, subclinical rejection is thought to be associated with worse graft outcomes. So the feeling is that if we can pick up this subclinical rejection through a protocol biopsy and modify our treatment or treat the rejection, that we can improve graft outcomes. Biopsy is at present the gold standard for detection and characterization of renal pathology. It allows for the detection of not only rejection of various kinds, but also tubular atrophy and fibrosis, tubular damage from other causes, as well as a variety of different infections in the kidney. So as mentioned, we do protocol biopsies at 6 months, and we do treat when we find rejection, not only cellular rejections and antibody-mediated rejection, but we also treat borderline rejection, typically with the steroid pulse and TAVR, as well as intensification of basal immunosuppression. Biopsy, although it gives a lot of information, does confer a fair bit of risk. Primary risk is bleeding. The allograft is a very vascular organ, of course, and bleeding can occur within the kidney, around the kidney, into the urine and other places. As a result, damage to the allograft may ensue, and you can also damage surrounding structures such as bowel. The risk of biopsy is heightened in many of our patients who are either on anticoagulation or have anatomic reasons why biopsy is more challenging. Biopsies involve a lot of stress on the patient in many cases and involve a fair bit of clinical resources in terms of clinic space, clinician time, other staff time, ultrasonography, et cetera. Lastly, the interpretation of the biopsy can be challenging. There is sampling error that can occur, and further, there's well-documented inter-observer variation in the reads of biopsies amongst pathologists. As an example of some of the risk of biopsy, I include some ultrasound images from a recent complication of a biopsy in our own practice, in which a large subcapsular hematoma formed in a patient, necessitating operative evacuation. So part of the story is to the usage of non-invasive means to monitor allograft function in our practice relates to COVID-19. So we're located in New Haven, Connecticut, just 70 miles from New York City. And we were very hard hit by the first wave of the COVID outbreak in the United States. Connecticut had over 35,000 cases and 3,000 deaths. Yale New Haven Hospital had at its peak over 400 COVID positive inpatients and a MICU service that nearly tripled in size to accommodate this patient flow. This greatly affected our transplant workflow. We suspended all transplants for several weeks. Transplant clinic visits were severely curtailed and replaced with telehealth visits. And environment, doing protocol biopsies as per our usual routine became difficult to justify. And this led to an acceleration of a process that was already underway for us, which is an examination of non-invasive methods of detecting subclinical rejection that we could use in place of protocol biopsies. So broadly speaking, there are two different methodologies of commercially available non-invasive tests for rejection. The first is to look for donor-derived cell-free DNA in peripheral blood. And the principle here is that when an allograft is injured, it releases more cell-free DNA into the bloodstream. And that DNA can be picked up and identified using next-generation sequencing techniques. And there's been a number of studies and a number of different companies that have developed this type of product. Most of the studies have been done in the context of for-cause biopsies. And the data have shown that cell-free DNA is pretty good at detecting rejections that involve the vasculature, such as advanced cellular rejections and antibody-mediated rejection. It's also useful in determining whether antibody-mediated rejection is present in the setting of de novo DSA development. However, these tests have not been well studied in the context of normal graft function and have been shown to be relatively insensitive to picking up more subtle forms of cellular rejection, such as BAMF1A and borderline rejections. The other major approach to non-invasive detection of rejection is a peripheral blood gene expression profiling test. And the principle of these tests is that gene expression profiles from a suite of genes identified in peripheral blood can be used to identify subclinical rejection. A couple of different groups have similarly developed gene expression profiling tests. The group at Northwestern, as shown in the Friedewald paper in AJT from 2018, developed a test that was subsequently commercialized as a TruGraf test. This test was specifically developed to detect subclinical rejection and was tested and developed specifically in patients with stable graft function, meaning a creatinine below 2.3 and less than a 20% change in creatinine in the time before the test was done. And the principle of this test was to pick up subclinical rejection so as to forego the need for routine protocol biopsies. And the test characteristics have been developed such that the negative predictive value of the test is designed to be quite high, 80 to 90%, although the positive predictive value of the test is only about 50 to 60%, depending on the prevalence of rejection in that population. Of note, the test is presently constituted is returned in binary fashion, either a positive test, meaning a non-transplant excellence, suggesting that there's rejection potentially occurring, or TX, transplant excellence, meaning the test is negative and the chances of rejection are only 10 to 20%. So at Yale, in the height of the Covid-19 pandemic, we elected to suspend our protocol biopsy program, and we substituted a peripheral blood gene expression profile test at the 6-month mark in lieu of a protocol biopsy. And our workflow was to follow up positive tests with a biopsy, and negative tests patients were monitored per usual practice. For-cause biopsies continue to be performed when indicated. Further, for patients who had new DSAs or who needed for-cause biopsies that were deemed to be quite risky, we typically did a cell-free DNA test. There were some challenges to moving to this new mode of testing that we encountered. The first was that we had to incorporate the gene expression profile test into the electronic medical record at Yale so that we could facilitate its ordering and also the return of results. This took some time to achieve, but ultimately it's been set up and is working quite well. The second issue has been insurance coverage. Medicare pays for the TruGraf test, but many other insurers either do not or require lengthy and challenging pre-authorization process, which unfortunately has limited, in some cases, our ability to use this test in patients who do not have Medicare coverage. In addition, it's a new test, it's a new technology, so there's been a learning curve and a period of education and gaining familiarity with the test that's needed to occur amongst all the members of our transplant group, including not only the nephrologists, but our surgical colleagues and the nurse coordinators who work with the team. So our experience to date is as follows. We've ordered about 31 tests on 29 patients. About 2/3 of those tests were done around the 6-month mark, meaning as part of our traditional protocol biopsy timing. 2 of those 31 tests came back as not performed. There were technical issues with the test or with the sample collection that precluded returning of data. One of those 2 cases, a subsequent test was sent and was performed adequately. So it's something that can happen, but is relatively infrequent in our experience. All but 6 of the tests that were sent returned as a transplant excellence. 6 of them from 5 different patients, however, came back as not TX. And amongst those 5 patients, 3 of them have been biopsied at this point. And 2 of the 3 biopsies actually returned as a 1A rejection. So in 2/3 of our positive tests where we've been able to do a biopsy, we actually did diagnose rejection in patients who otherwise appeared to be doing well. Beyond those 3, we have 1 patient who's awaiting biopsy, and we have another patient who is electing to repeat their peripheral blood gene expression profile prior to proceeding to biopsy. So to summarize our experience to date, about 80% of the tests we've ordered have been negative, which I think is to be expected in a group of patients without biochemical evidence of rejection. About 7% of the tests, of the patients rather, that we have tested with TruGraf have turned out, in fact, to have rejection, which again is in line or maybe even on the low end of what's been published in the literature. And also of note, 25 of the 29 patients have not gotten a biopsy and at this point are not scheduled for a biopsy either. And in those 25 patients, the TX result that we got from the test has allowed us to have some measure of comfort that rejection is less likely in that group. I'd like to briefly share a couple cases to illustrate the way in which non-invasive testing has affected individual patients in our practice. So the first is patient FB. This is a 69-year-old man who developed end-stage renal disease due to diabetic nephropathy and underwent a deceased donor kidney transplant that was complicated initially by delayed graft function requiring dialysis. Further, the early postoperative period, even after graft function took hold, that early postoperative period was characterized by several AKIs and hospitalizations. That led to 2 different biopsies in the early months after the transplant, both of which showed not rejection, but just tubular injury. And ultimately, it was felt that the patient's graft function was affected by intermittent congestive heart failure exacerbations that were associated with worsening aortic valve stenosis. So at about 4 months after transplant, the patient went a percutaneous aortic valve replacement, a TAVR procedure, with subsequent stabilization and improvement both in cardiac and renal function. So as the 6-month time point rolled around, we proposed a protocol biopsy to this patient who was already somewhat gun shy after having had 2 prior biopsies, and he was not enthusiastic about doing yet another biopsy. So we ordered a gene expression profile test at that 6-month mark, and it returned as not TX, suggestive of a possible rejection. Sure enough, we did a biopsy, and it came back as acute cellular rejection, BAMF class 1A, and he was treated with a steroid pulse. Second case, MP. This is a 24-year-old woman who has ESRD due to congenital abnormalities of the urinary tract leading to chronic reflux and scarring of her kidneys. She had a preemptive living-related donor transplant that went very well. At the 6-month mark, she refused to have a protocol biopsy. She is, I think, as are many young patients like this, somewhat headstrong, not enthusiastic about medical tests. And we eventually persuaded her to undergo a TruGraf test, a peripheral blood gene expression test in place of the biopsy. This test also returned as not TX. And we subsequently convinced the patient to undergo a biopsy on the strength of those test results, suggesting that her chances of rejection were substantially higher than had the test come back as TX. Patient then did agree to a biopsy, which actually found no evidence of rejection, but nonetheless, I think both the patient and the care team were more satisfied with this workflow than if the patient had simply refused a biopsy and we were unable to obtain any more information. What comes next? As I mentioned, our particular center's movement into the use of non-invasive tests of allograft function was motivated in large part by constraints imposed upon us by the COVID-19 outbreak. But even as that outbreak has receded, I think that gene expression profiling and cell-free DNA are going to be part of our toolkit for allograft monitoring going forward, as illustrated by both of those cases that I just discussed. There are studies underway to characterize the performance of these different tests of rejection in a wider range of clinical settings with greater numbers of patients. There's a number of new tests under development, some of which combine different types of analysis or look at other biofluids such as urine. So ideally, future iterations of these tests will improve upon the sensitivity and specificity. And ultimately, we look forward to studies that are able to show that the use of non-invasive testing can improve hard outcomes like graft and patient survival and are cost effective. So with that, I will conclude and take any questions.
Thank you, Dr. Marin, for that presentation. I have a couple of questions maybe as the questions on chat are coming in. Is COVID still affecting your biopsy practice?
At this point, the COVID-19 numbers in our local area in Connecticut have diminished substantially. We have fewer than 5 patients probably hospitalized at this point. So our practice is largely back to normal with regard to the biopsies. But as I mentioned, the experience we gained with gene expression profiling and cell-free DNA has made it such that we continue to use these tests even though our biopsy practice is available once again as COVID-19 has receded.
Are there situations where a biopsy is not pursued in the setting of a positive gene expression test?
Yeah, so the question as to how to use biopsies in conjunction with the gene expression profile testing is one that's evolving. Our general practice to this point has been a suggestive biopsy in cases where the gene expression profile test is positive, reasoning that the pretest probability that we're going to find something is fairly high as a result of that positive test. There are cases where patients want more information or we feel clinically that we need more information and we elect to wait for a repeat gene expression profile test, typically a month later. If a second one's positive, we generally push very hard to get a biopsy done in that situation. To this point, we have not treated ever without a biopsy. We always have done a biopsy and not relied merely on biomarker testing results.
What is your sense of the patient attitudes and responses to gene testing? How do they feel about it?
So far, I think the response of patients has been very positive. As I mentioned in the talk, a lot of patients are anxious or uncomfortable about pursuing biopsy and are very open to doing a non-invasive test that we feel can help guide the true need for a biopsy. The tests do require some additional education to the patient since they are sort of a newer product, new to us and new to them. But in general, I think patients are very receptive to having these sort of tests done and are appreciative to have that option in cases where there's reluctance to do a biopsy.
When do you repeat the genetic expression testing to confirm a positive test versus proceeding straight to biopsy versus initiating treatment without a biopsy?
In general, we, on the strength of a single positive test, have been proceeding to biopsy. So far, there's not been any cases where we've elected to treat just based on the results of a gene expression test. Occasionally, as I mentioned, we will wait and repeat a gene expression profile test a second time, and we've done that in situations where the biopsy is especially technically difficult, or the patient is especially resistant to a biopsy. We've reasoned that if other parameters are stable, it's safe to wait an additional month or so to repeat the test and make a decision about biopsy based on the results of that repeat test.
Thank you, Dr. Marin, for those remarks. I really appreciate you sharing some time with us.